Hello, I'm Christine Hamori, and this is the Plastic Surgery Channel No Spin Live. Today, I'm going to be talking about how to re-enter into your practice. And I'm honored to have my guests of John Cook from Chicago and Jim Namnoum from Atlanta. And we're going to discuss some tips on coming back into your practice.
It's great to see a lot of good minds trying to figure out, talking to friends, and then certain groups that are getting together to try to formulate a way to do this. But basically, you could look at it in terms of what you do before the patient even comes to the office, and then when the patient arrives, and then when we treat, and then kind of after we treat. Certainly one thing has been the use of video consultation, which has been tremendous, in able to maintain contact with existing patients if there's new patients who want to talk to us. But in terms of safety of the office, certainly we want to have a protocol where we ask patients obvious questions. Are you running a fever? Have you traveled? Have you come in contact with anyone with COVID? One thing I purchased for my practice is actually one of those infrared thermometer systems, so that you can actually not have to touch the patient, because the patients aren't keen on having temperature devices touching them. So as they come to the office, they'll be able to use that much as they do in the airport. And then obviously not having patients wait in the office, but coming right to where they are. One of my locations is in the suburbs, so a lot of people come up with the idea of actually having patients wait in their cars if you're in that type of setup, and then texting them so that they can come in. So, that's kind of how you get them into the office. Once they're there, obviously patients want reassurance. I mean, all of us are using very good, as we have for years, really good techniques for keeping our treatment areas clean. And we want to obviously maintain that, but let our patients know. But we're also looking at ways to make it even safer. Once we have more effective masks that are generally available, I'm going to have my staff definitely wear those. And if we're doing any sort of off-face treatments, I'm going to have the patients wear those as well. And we're also looking at something called hypochlorous acid, which, as you both know, we use a lot in our practices for breast implants. I've used it for quite some time, just whenever we do a facial injectable to help prep the skin. But we're looking at ways where we can actually deliver that into the nose and mouth in a very, shall we say, pleasant way for the patient, so that that should, if someone happens to be a carrier, that should help as well.
I was reading about a little bit with the topicals, whether for patient use or on surfaces. The contact time is very interesting, how long it is for some of these. And I guess the hypochlorous is a 0.025% hypochlorous acid. Is that correct? Do you know
That's
anything
correct.
about the contact time that you need to have for it to be effective?
I have not seen any data very specific on that. Does Jim know anything? Or, we use it a lot. Certainly when we're using it with a breast implant, because almost everyone's using that in the pocket now. Most people keep it in there at least for 2 to 3 minutes. That's, kind of become the standard. But, how much of that is protocol versus science?
Right.
I think you bring up, I could sort of expand a little bit on taking a broad approach to this, sort of getting to a bit of what John's talking about. So what we want to do is, certainly we want to help patients understand that we're keeping the office clean and we're keeping the staff, we're making sure the staff is healthy. So as part of this, I think for you, Christine, and for John and I, and for all doctors, plastic surgery and other specialties, we need to create messages for our patients showing them that we either are using, for example, dry hydrogen peroxide, spraying it around the office, or cleansing the surfaces. I think what's also important to let the patients know is that we're testing our staff. And frankly, what we'd like to do is to test our staff weekly with a PCR test. Now that's not available yet, but we're trying to get a method in place, along with, kind of John's comments, to be able to offer weekly testing of the staff, testing the patients. We've got the antibody test, which, is one piece of the puzzle. I'm not certain. It's got a specificity, and it's got a sensitivity and specificity of 90%. That may not be good enough. There may be a better test. But certainly we want to clean the surfaces and demonstrate for the patients we're doing that. We want to test our staff to make sure our staff is non-infectious. We want to do that as well for the patients to help them better understand where they stand. And then frankly, again, the other broad picture John addresses is we want to use virtual consults as a screening technique so that it would limit patients' time spent in the office. As John noted, they could spend time in their car if we're backed up. But by virtue of the fact that we could limit the exposure in the office by pre-screening them, that might eliminate shopping around, waiting times, unnecessary exposure. And frankly, those are the tools I think we're going to need going forward to over the next, not just the next 2 or 3 months, but frankly over the next year, or until there's enough herd immunity and or there's a reliable drug therapy to treat people or a vaccine. So I think all these measures are going to be necessary going forward.
Do you think there'll be restrictions the government will make on how much contact we can have with patients? Do you think that we're going to be restricted, considered kind of elective type, procedures? I mean, are they going to say, okay, you can sure inject someone's lips or you can do a breast augmentation? Do you guys think we're going to be kind of restricted by the government, or?
I think that each state is going to have different restrictions, and I think the political climate is going to vary from state to state. I think the real issue is not exactly any specific procedure, but length of time. And I think there is a difference between, say, doing a local anesthesia case versus a general anesthesia case involving intubation, because once intubation's involved, we know that that's an act where there can be aerosolization of COVID if it's for some reason not been detected. So it puts the teams at risk. And the protocols keep changing on that. The Texas group, which has really taken the lead on investigating this, had a long session with a very experienced anesthesiologist. And, he was going through how the different protocols had changed. At first, it was kind of everybody, if there's an intubation, 14, 15 minutes, even 20 minutes, nobody else could be in the operating room. Same thing with extubation, but now they're changing protocols, stratifying. I think we'll be stratifying patients into risk groups probably. And I do think the thing that will return probably the quickest are some of the facial injectables, procedures like that, local anesthetic procedures. And then as you move up in terms of intensity of anesthesia, that's where it may take us a little longer. We'll just have to see.
I was talking to Steve Teitelbaum. He's in LA. He's a good friend of all of ours here. And, he said that LA is completely shut down. No one goes outside. No one's walking in the streets. I can tell you in Atlanta, everybody goes outside and the streets are jammed with people walking and bicycling and whatever. I'm curious, what's the mood like in Boston? Particularly
more like LA, very few people out. If I go out, I'm in a suburb about 20, 35 miles south. I always go out with a mask to the grocery store. If I'm going running, I have a little cowl on that I'll pull up if I'm running by people with less than 6 feet. They've closed the beaches completely here because people were going there and congregating. I think the toughest age group to manage are the teenagers. They tend to want to pile into a big SUV and go to the beach or go places, and they still have trouble controlling that. But it's a pretty somber environment, and we're frightened because right now we're on a big trajectory upwards, like New York. Luckily, I'm in the suburb is not so crowded as downtown Boston, but it's very quiet. There was an article in Scientific American I was reading earlier today, and it was interesting because they were saying the important thing to detect are the neutralizing antibodies. And we really don't know, since there's that glycoprotein spike, I guess, and apparently sugars are difficult for the body to detect and make antibodies too. So it'll be interesting what kid actually has neutralizing antibodies. And I think that's maybe Cuomo has found a company that does that. Why else would he buy so many kits? But they're kind of tight-lipped on which company it is, I see. And I wonder if that's because they're afraid everyone's going to try to invest in that company, or what the reason is. But
I'm not sure. I'm happy to share with you the information that we have. I was just excited to find a test that was readily available, inexpensive. Of course, if the information's bad, it's maybe worse, obviously, than to think.
Did you ever have a person that was positive with the test?
No, and I think that's, so, I thought about that. I said it would be nice to have a positive. We haven't had one yet. I think it's reflective of the fact that there are very few cases in Georgia. We're on an upward swing, but relative to the population, there's just there's very few cases in Atlanta. So as a consequence, it doesn't surprise me that no one's positive. I don't think too many people have been exposed to it. I was curious looking at that's why I was interested in hearing about the Boston experience, because I was curious to see so many cases south of Boston, in Brockton, and I mean,
Yep, Plymouth County, that's where I am.
Why is it in Brockton? I was curious why.
It's a poor area. It's you know, it's not, it's a more working class area. There's some pockets that are very poor in that area. I think it's part of the maybe don't have access to health care, and I mean, that would be one of my thoughts. Similar, Chelsea's another area up in Boston. It's another really hot area. And
well, I think
really
density too is an issue that really comes into it. Certainly, I think certainly part of the explanation for New York is they're denser, and then certain neighborhoods obviously aren't as well served, and you know, there can be an element of behavior too. In other words, if there's a lot of people, as you mentioned, congregating or whatever, that can affect it. We've been lucky in Chicago. I mean, for being such a large city, we seem to be, at least at this point, blending the curve better than some
people on the streets there, John, at all?
Or you know, they are, but people have been, even before the actual order, and it was just something about Chicagoans. They're pretty considerate people, and everyone just gives way and gives like a wide berth. And most people are very considerate. But the first day, a couple of weeks ago, there was a day where you know, the weather popped up to a really wonderful level, so everybody thronged to the lakefront. You know, as I came home from my office that day, I said, "Oh boy, this is going to be a problem." And sure enough, the mayor said, "Okay, we're going to have to close the lakefront and the parks," which was
the weather in Atlanta, Jim's probably nice, right?
Oh,
you guys
God, it is. You know, this is Masters Week. It's spectacular. It's spectacularly beautiful, and honestly, I live in a neighborhood where there are often a lot of walkers and bikers, but I would say the number has maybe tripled. It's almost like the streets are jammed with people getting outdoors and walking around because I think they feel so trapped. That's why I'm curious that the mood seems to be very different depending on where you are regionally.
Oh yeah. The grocery stores only let in 40% of people at a time. There's taped arrows on the ground for the direction that you have to go. And you have to stand back, and there's limits, of course, on the toilet paper, certain products you can't get. And people are, you know, if you get near within someone of 6 feet, they'll kind of back off. You know, people are anxious in the grocery store. I don't like to go there.
Interesting.
Yeah, in Chicago, I think, I mean, we're doing a lot of the same things, but I don't think the mood is all that bad. There's kind of generally a kind of a spirit of, I think people are very polite and cooperative here, which is nice. I haven't seen a lot of what I'd consider, obviously people are anxious, but in terms of their day-to-day interaction, I'm not seeing a lot of really overtly anxious behavior on the part of people when they're in a place like a grocery store or whatever.
I mean, see, that is more of a stress for me for bringing my staff and starting to talk about that with my staff now when the level of tension is so high. Because I have a feeling if I bring them together at this point for a Zoom meeting that they're going to be like, well, I don't know. I don't feel comfortable in the injection room if you're going to inject someone's lip. It'll take like one person to say that, one MA, and they're all going to kind of just not want, or the OR nurse will say, no, I don't think we should intubate. You know, they'll just come up with their ideas. So right now I'm kind of waiting for things to calm down, obviously be safe, but you know, it's good that you're talking to your staff now, but just in case it comes up and gets to be, it's good to have a plan now in place so that you don't have to institute it now like I need to. I have to wait to the other side of the curve to start really talking to them and learn more data about how to do it correctly. Thank you guys. And for more information, you can visit theplasticsurgerychannel.com.